First of all, I would like to thank organizers and Novartis for the opportunity given. So today's talk is on what is the best treatment strategy for hormone receptor positive, HER2 negative, metastatic or advanced breast cancer. So in such situations, I would like to say the revolution imatinib has brought to the CML, that work has been done by Ribociclib or Crixana in hormone receptor positive metastatic breast cancer. So the trials have proven their worth in the long run. And the next question, many a times as a clinician, we feel what is the real evidence? So that is what we are going to discuss. What is the real world evidence of ribociclib? So we'll be discussing patients beyond like more than 8,000 patients data. We'll be discussing next. So as a clinician, whenever I see a patient, any patient for that matter, next thing in my mind, what is the ideal situation or ideal things which I attribute to a patient? The first thing, patient should have the best response rate, longevity as far as possible, and the second thing, minimum complication, so that my headache is a little less. So this molecule ribociclib has touched to that point, which is like minimum complications and overall survival, as all the trials have shown. It is at par or much more, very impressive in terms of in last 2-3 decades. Not a single molecule has given such a wonderful overall or overall survival results in hormone receptor positive disease. So coming to the overall survival, how do we define it? It is defined as the time from randomization until death from any cause, and is measured in the intent to treat population. So it is the whole population we are measuring, and that is the gold standard parameter which we commonly use in all the trials. So coming to the evidence, what has been the that is what I'm pitching into the ribociclib, how it changed the whole perspective in terms of advanced breast cancer in hormone receptor positive. Look at the slide where we can see, be it a first line, be it a second line, be it a premenopausal, which is less aggressive, which is aggressive, and postmenopausal, which is less aggressive. In our, be the endocrine therapy partner, it may be AI, fulvestrant, whatever is the combination or whatever is the line of treatment, the OS has been demonstrated significantly with the ribociclib, which is not in palbociclib, and in abemaciclib, Monarch 2 has proven, and Monarch 3, the results are pending. So ribociclib has consistently shown in all the risk categories or line of therapies and proven its worth for the overall survival. So how does it impact the overall survival? If you look into the what is the added benefit with the ribociclib, first line postmenopausal with AI, first line with postmenopausal with fulvestrant. So changing the partner, we always have a more than a year of addition of median overall survival. In premenopausal subgroup with endocrine therapy, again 10.7 months. So it approximately turns out to be 1 year, with irrespective of the group which we are addressing of the patients, irrespective of the line of the treatment. So what is the backing apart from the clinical trials? As yesterday I was discussing clinical trial patient subgroup in clinical trial are worth only representation of 2 to 4% of the real world patients. 95-96% times clinical trial subgroup does not fit in. So we need a real world evidence, and the real world evidence for the ribociclib comes from complement trial and Ribana trial. So it included, it's a huge population, 3,000, more than 3,000 in complement, nearly 2,600 in Ribana. So we'll just quickly go through what is the schema. So in complement trial, 3,000 patients, men and women, no prior endocrine therapy for advanced breast cancer, DFI of more than 12 months from the completion of the neo or adjuvant therapy required if NSI. Then ECOG performance 0 to CNS mets permitted if more than 4 weeks, which were not permitted in the most of the trials of the CDK4/6 inhibitors. So primary endpoint was safety and tolerability. Secondary endpoint, time to progression, overall response rate, clinical benefit rate. Drybana, again, more than 3,000 patients planned, enrolled around 2,600. First line setting, Ribociclib plus AI plus Pervistin, and second line, all further lines. So criteria were more or less similar. So coming to the complement trial, it is the largest real world study across the CDK4/6 inhibitors. That itself is a great complement for CDK4/6 trials. So what is the diverse population which we see clinically day to day? Patients coming with the CNS metastasis, nearly 51 patients, one of the largest. Prior chemotherapy, 194 patients. Visceral metastasis, nearly 2,000 patients. ECOG PS, 110. So it's a diverse population, including all the high-risk subgroups which we commonly encounter in the clinical practice, which is not included in the most of the clinical trials. So coming to the safety profile, that is the most important point to me in terms of reducing my headache while treating patients. So if there are minimum side effects, I'm more than happy. So if we look into the overall adverse event rates, it's like 98%. Treatment related are 95. So how much of them are serious adverse events? Like treatment related, only 6.3. Very impressive. And out of these, like only 5.5 are grade 3. If we look into the fatal side, again, it drops down to less than 1%, which are treatment related. Again, impressive, quite impressive. Fatal side effects are less than 1%. So you are quite happy treating such patients where we have overall serious side effects or fatal side effect less than 5%. Sometimes we may not comply with the full dose treatment in patients, which is recommended in the clinical trials. So it is measured in the adverse events leading to discontinuation. So how many patients require that? Nearly 13% of them require dose discontinuation. And because of grade 3, it was like 7.3. And adverse events leading to dose adjustment or interruption, nearly 75% patient. Huge population, nearly every third patient out of 4 will require dose adjustment. So that is probably clue for all of us in the form of this complement trial, where we should be very aggressive in terms of modifying dosages if required. So that was about the safety. And the second point, which we always vouch for, is the efficacy, is prolonged TTP with high event-free probability. So the first parameter, which I said at the outset, we should be happy if patient is responding, especially for a longer periods. We should be more than happy. And if the patients are paying, they'll always ask, I'm paying so much of amount of money and still results are not, if results are compromised. So with this, we can say nearly with the median TTP of 27.1 months, we have at the end of median PFS of 26.7 months, which is slightly more than what is there in the trials. Improved response rates. If we look into the overall response rate to the tune of 70%, sorry. And if we look into the patients with measurable disease, nearly 43% patients will have the response, overall response rate. Coming to the clinical situations which we encounter, as the patient's longevity increases, CNS mets tend to much more commoner. So if we look into the clinical trials, Mona Lisa 2, 7 CNS mets excluded. Mona Lisa 3, 8 patients with stable CNS metastasis. Palema 2, 3, hardly few patients, and Monarch excluded CNS mets. So in complement, it's a real world data, phase 3B real world study included 51 patients with the CNS metastasis. So what happened to them? We'll see the next slide. So overall population had 27.1 months of PFS, and patients who were included in the complement trial, they did not reach the median TTP at the time of analysis. So we can see the blue line, the faint blue line is still going parallel to the median. And also, if we look into the other clinical subgroups where we are interested, considering median overall TTP of 27.1 months, patients with prior chemo, history of prior chemo, median TTP is 18.4 months, matching nearly 1.5 years. ECOG PS2 nearly 1.5 years, more than 1.5 years. Visceral metastasis 12.7 months, a year. Visceral metastasis and ECOG PS again nearly 18.8 months. So 1.5 years. So 1 to 1.5 years even in high risk subgroup. The one point patient should be happy about is patient's quality of life. Even the medical targets are patient's response rates, overall survival rate, minimum side effects, but the end effect to the patient's quality of life should be maintained. That is how patient sees. Once the patient has a good response, the next question patient asks us to, can I go to my work? Can I drive the car? Can I work for 8 hours? Can I work for 7 hours? So that is the question. So that is judged by the quality of life, how the patient feels. So if patient feels and patient's quality of life is improved, then patient definitely has a productive life. And if we see all the parameters in the FACT-B, emotional and functional well-being, so overall parameters are much better in ribociclib treatment. The second trial, which is generating a real-world evidence, is RIBANA, clinical evidence from the RIBANA. So it has 3 subgroups, CDK4/6 inhibitor plus AI plus endocrine therapy or chemotherapy. If we look into the patients with ribociclib was given in the metastatic CNS and liver and lung mets, nearly 42% patients. Bone mets only, nearly third patients. Chemotherapy received in nearly 2/3 patients with metastasis in CNS, lung, liver mets because of due to visceral crisis. So that is quite common. So what were the results? This is unadjusted median PFS with the RIBANA study. So if we look into all the parameters, chemotherapy fared only 15.3 months versus ribociclib plus hormonal therapy resulted in 3.1 months, more than double that of chemotherapy alone. And endocrine 25.7 months to 31 months. So it's 5 to 6 months of difference. Safety treatment, we always worried about the QTC prolongation, which were quite highlighted in the clinical trials. But in real world, if you can see grade 3 and 4.6% patient had a QTC. It is definitely class effects. It was not seen in all other cohorts. So, and transaminitis, again, less than 2%, grade 3 and grade 4, increase bilirubin 0.2% minimal. So overall outcomes reported in phase 3 trials are achievable in real world practice. If you can see the combination of or comparison of real world evidence versus randomized controlled trials, these are matching, median PFS are matching to the clinical trial evidences. So whatever the clinical trial subgroups were excluded, even those high risk subgroups after inclusion, that we are reaching to the median PFS. The one thing I would like to highlight in this chart is discontinuation due to adverse events were 12.9%, 13% in complement trial, and all clinical trials were to the range of 7 to 8%. So dose reductions or dose discontinuation should be aggressively sought if there are side effects. So this is the guidelines through NCCN and ISMO guidelines also recommend in advanced metastatic breast cancer with hormone receptor positive. So comparing to the ISMO MCBS score, which is a magnitude of clinical benefit rate, this is scaled out of 5. So if we see all the parameters, all the clinical trial parameters, this is the only CDK4/6 inhibitor which achieved the score of 4 in first line and second line postmenopausal patients, and 5 in pre and perimenopausal patients with hormone receptor positive or HER2 negative advanced breast cancer. So whatever the clinicians' intent are, like getting the good response rate, getting the longevity, or obtaining the overall survival effect, and minimum side effects, how are these obtained? So there is a rationale behind it. The rationale is selectivity and off-target inhibition. If we see all the CDK4/6 inhibitor Ribociclib has minimum off-target inhibition, and that is why the side effect profile is also minimum as compared to Abema and Ribo. So Crixana or Ribociclib preferentially inhibits CDK4 as compared to CDK6. That is why it is on target and minimum off target. While Abemaciclib, it inhibits CDK6 as well. So it has more different and adverse event profile in terms of diarrhea, venous thromboembolism, or even sometimes ILD. So off target effect of Abema is larger as compared to Ribociclib. And the preferential inhibition, if we look into the CDK4/6, so Ribociclib has the highest free drug and preferential drug inhibition as compared to the Abema and Palbociclib. To summarize my presentation, so whatever clinical trials has demonstrated the overall survival or median PFS benefit, that has been translated in real world even after inclusion of high-risk patients, including CNS mets, liver mets, or visceral diseases. Irrespective of the postmenopausal perimenopausal status, even in first line and second line, the quality of life is much better in with the use of Ribociclib or Crixana, and it has demonstrated the patient more than 600 patients in real world scenario. And the rationale for that is because of the CD4 preferential CD4 selectivity and minimum off target inhibition and also the drug concentration, free drug concentration of Crixana is much more common. Thank you. If there are any questions.
Thank you, sir. Thank you
I would
for
like to just share my clinical experience. Few of my patients are since last 4 to 5 years. They are on Crixana, and the patients had come with extensive. The few of the patients came with the extensive visceral mets, including like pleural effusion, bilateral pleural effusion. Patient went on a ventilator. So initially we were little skeptical, but with the low dose we started, and then patient started responding. The patient went on for like pleural effusion was subdued, and then even patient was off ventilator. Now such patients are coming alone without anybody's support. So like there are few excellent experiences that we have seen in even in very advanced and even in visceral metastatic setting. Thank you.
Thank you, sir. Thank you for a nice talk. Now